have it in the bag. Open the top part, but leave the rest of it closed. And you're going to check that cuff to make sure that it works. Because you don't want to intubate this person and then find out you have a hole in your cuff. So you're going to check it while it's still in the bag. So all you have to do is hold it, take your syringe and just put some air in it. And you're doing this, somebody else is still bagging your patient.
Here, in check-off, do you want us to actually set up the suction and all that, or just have the actual yank arrow just next to it and say, I've set up my suction?
Yeah, you can just have the yank arrow and a suction catheter as well.
Right, okay.
Now, as you can see, I can see that that cuff is completely blown up, and I can even check to make sure that it's going to hold air. And I still have not touched anything inside there, just the outside. I have not contaminated my tube. Make sure cuff. That's vital. Completely deflate that cuff. You can leave the syringe attached. You're then going to insert your stylet again while it's still in the bag. Now it gets to be a little where it becomes your personal preference, and by practice, this is just stuff you get by practice, doing it over and over again. You get to see what works for you. Because while it's still in here, once that stylet is in, you can bend it any way you want. Some people prefer that little hockey stick on the end. I've seen some anesthesiologists bend the thing completely like that. But they get it in. I like the little hockey stick approach. You're then going to take some Surgilube. Just put a little blob somewhere.
Is that
You
still
don't-
sterile?
Huh?
You said that's still sterile inside
Right.
the containers.
Exactly. I haven't touched anything in there yet. And by putting that on, I just did that, but I didn't even touch it with that.
Mm.
Your co-worker is still bagging. And then you can tell them when you're ready. And then they'll just move away, but they'll stand right there close by. You also want to make sure that you have your easy cap there and open. Because I'm going to have to open it. Whether or not you use the straight or the curved blade, again, is personal preference. Whichever one works best for you. I would practice with both of them until you get which one is easier for you. You're going to find doing a real person is actually easier than doing these plastic mannequins, because these guys are stiff. They don't give at all. But a real person, I think, is a little easier. What do you think?
Loads.
Make sure they're in the sniffing position. One thing that you will not ever do is this. You want to get them in the sniffing position. You will not put your hand under here and do that, okay? You're going to use the chin lift position method, okay? You're going to tell your coworker that you're ready. You will hold the laryngoscope down like so. Don't hold it up here. You're going to hold it kind of down so you have complete control. It's made to be held in the left hand. So for those of you who are left-handed, I know it gets a little a little difficult. But Ellen does, she has no problem with it like this, right? She's left-handed too. Do not the tube down this little curve here. This is supposed to be your line of vision, so you can actually see the cords when you're sticking the tube in. The book tells you to put it in on the right and lift the tongue over to the left. And you also want to lift up, not rock back on the teeth.
Then you break the teeth.
Huh?
So then you can break their teeth.
Then you can break the teeth. But if that's your only option, they can get a pair of dentures. The other thing is they're going to die.
hospital
So,
pays for it.
yeah. Huh?
The
It's like when
hospital
you're
has
doing
to do it.
CPR. If you break ribs, you break ribs. Ribs can heal, but if you don't do CPR, they're going to die. So, now, some doctors and anesthesiologists like to use this finger motion to open the mouth. One here, and they do that. I don't do that, because if they bite down, you're going to lose your finger. you want to physically see the vocal cords. And sometimes that's harder, it's easier said than done. You're going to go in on the side. And as I said, you want to physically see that tube go through the cords. Immediately remove this. Close it, don't leave it open. Immediately remove this. Blow up your cuff. If you blow up your cuff before you remove the stylet, the patient has nowhere to breathe. The stylet's in the tube and you just blowed up the cuff. So even if they were trying to breathe, they couldn't. Attach your easy caps. And now somebody, your co-worker who was bagging for you, is now holding this, or you're going to hold it, and then you're going to bag. You're looking for two things: bilateral chest excursion, and whether or not your easy cap is changing color. You're going to bag them 3 or 4 times before you go by this, because sometimes those first couple of breaths you're not really getting good gas exchange, or if you're doing compressions, they may not have any good perfusion going on, so there's no CO2 being brought back to the heart. So you're not going to go with the first or the second time you do it. You want to. I think, does the book say 2 or 3 or 5 or 6? I think it says 5 or 6. What does Egan say?
5 or 6.
5 or 6.
And you never let go of the tube.
Never, ever. If you're not holding it, your coworker is. So if you let go, like what I'm doing, if I'm doing this and I know I'm going to have to let go for something, I will let that person know. Can you hold it too? Huh? Did you say something?
Oh, no, I was asking him, that's fine. I was just asking him a question, you would say the cup, I couldn't say.
Oh. So then, and you notice that I am holding the tube and the face together. I'm not just holding here, the tube and the face. So that if they start to move around, my hand is moving with them. And now you have to, the next thing you have to do is secure this tube in place. Now, as I said, there are several ways to do it.
Do you check the
Do you
lip
have the tape?
prior to securing?
Excuse me?
You check the lip line prior to securing so you have your measurement?
Yeah, because I already said you have to document that. That has to be put in your documentation.
So did you put a piece of tape here to,
Some
before you
hospitals
secured
do,
or
some
no?
don't.
What do you want us to do for the check-off?
Do you guys put a marker tape on the? No.
Just listen for equal breath sound, see if you have a good color change.
Yeah, but
Secure
some,
your
you know,
tube
some
and then
hospitals, some therapists like to put a little piece of marker tape here. The trouble is, you have to keep changing that.
Do you want us to just say we documented where it
You
was?
document the
Okay.
centimeter markings there.
Usually like an old lady, it'll be around like 19, 20. With like a size 7 tube. If you have like, you know, a middle-aged woman, it's usually around 20 with like a 7.5. A guy is an 8.0 and that's usually around like 23, 24.
Now, somebody's holding, somebody's bagging. Now, according to your textbook, one of the ways to do this is using tape.
For their checkoffs, Mary, what way do they have to do it?
One tape way and one of the
Maybe.
commercial brands. I don't care which one.
We get to choose or we'll choose for us.
No, you have to do both.
No, you can just choose whichever. You can either use the Hollister or you can use this one.
Okay,
Because those are the only two I have, actually. But you have to also do the tape.
sure.
I will also show you the Mama's Medical Center way.